applied healthcare, so primarily within the fitness industry. So a lot of fitness programs that are out there for people who aren't dizzy don't include a component that stimulates the vestibular system, and they should, because the more you use it, the better it works. And so we're trying to promote awareness of the inner ear and what it does for you, and how fitness professionals such as personal trainers, physiotherapists who work in gyms can use vestibular exercise to promote good balance even in people who aren't dizzy. Because the evidence does suggest that if you work the system, it improves balance in everybody, not just people who are dizzy. So that's what we're trying to do with vestibular health. So I'm afraid we have to do a bit of anatomy before we start so that you understand my discussion about different vestibular disorders. So my plan is to tell you a little bit about how the inner ear works in terms of balance rather than hearing, and then to go through some of the more common things that I see in clinic and just explain exactly what we think is going on with each of those problems and the type of symptoms that they cause. And then at the end, I'm going to talk a little bit, very briefly, about what you can do to help people who are dizzy. I don't have time to cover everything. To start with, we're going to talk about anatomy. And I've got a few props, which is lucky because I don't have the slide. So I'm going to pass this round. This is a little glass block with, it's not a real inner ear, but it's the right size of an inner ear. Whenever you come to talks like this, they always do have a really massive slide up that shows you this lovely picture of the inner ear. It looks enormous. But I just want you to see how small it all really is, because it just shows you how brilliant the inner ear really is. The human cochlea, the bit that does the hearing, is the size of half a garden pea. Just think about that next time you're having a tea. That's the useless fact for the day. And we're going to talk about the structures that are attached to the curly snail bit.
Did they give you one? Did they give everyone that finished the course one day?
No.
How did you get that? I've never seen that in a key room.
At some sort of audiology conference somewhere. So what we're going to talk about are the bits of the human balance system, and you have 5 sensors on each side. So there are 3 semicircular canals, 3 tubes, and they sense head tilt in any direction. So anytime you move your head independent of the rest of you, it's the semicircular canals that are functioning to tell you about that head movement. So they measure changes in head position and tell your brain where your head is in space and how fast it's moving. There are 2 other balance organs in the inner ear, and they measure head movement in a line, so forwards, backwards, side to side, and up and down. And they are there to give you your sense of which way is up. So they give you a sense of gravity. The 3 semicircular canals are named by where they are in your head. So there's a posterior canal, which is pretty much like your outer ear, so inside your head and much smaller. And that is called the posterior canal because it's at the back. There's an anterior canal, which is poking out as if you imagine an ear coming out like this, and that's called the anterior canal because it's at the front. And then there's a horizontal canal which sits like this in your head, measures horizontal head movement, and that's the horizontal canal. So those are the 3 canals that sense head tilt. The other 2 sensors in the middle are called the utricle and the saccule, and they measure this linear head movement and give you your sense of which way is up. The canals are full of fluid, and when you move your head, the fluid moves in the tube and it bends some little hair cells at the end of each tube. And when those hair cells bend, that's what tells your brain that you've made a head movement. So that's the way the canals work. The 2 other balance organs in the middle, they work in a slightly different way. So you have one that sits like this inside your head, and one that sits like this. And if you imagine they're like a little bed of nails, so there's one on each side like this with little nails sticking out, and then there's 2 more big nails sticking out. And they sit there like this, and on top of the bed of nails, the little hair cells, there's a pad of jelly, a bit like a duvet, that sits on top of them. And when you move forward, the bottom of the hair cells moves with you, because it's attached to your skull, and the jelly will lag behind and then catch up. And as it lags behind, it bends the little nails, the little hairs in between, and that's what tells your brain that you've moved forward. And it catches up because you've stopped. To keep this jelly in place, it's weighted down with some little particles, crystals, like chalk dust, microscopic. Sometimes people call them stones or debris, but they're absolutely tiny. It's like dust, really. And it sits on top of this jelly pad and it weights it down. And it's that mass that gives it inertia so that it will lag behind and then catch up. It keeps the jelly in place. And one of the things we're going to talk about later, sometimes these little particles can become dislodged from the jelly and then they start to cause problems in the inner ear. So that's why you need to know that in advance. So that's how the inner ear works. So these hair cells, whether they're in the utricle, the saccule, or the semicircular canals, it's the hair cells that are doing the work. They turn the movement of the fluid into an electrical signal that's sent up the nerve balance to your brain. Your brain processes that information, processes that information and uses it to help you orientate yourself in the environment. And it doesn't do that on its own. So it doesn't just gather information from the inner ear. It's also gathering information from your vision, so how the world is moving past you, what kind of environment you're in, and visual environment you're in. Is it very complex? Is it moving? Are you on a pattern floor? Is there strip lighting above you? That kind of thing. So your brain is also gathering information for your balance from your vision. And when you become the time that you become aware that that's happening is, for example, I don't know if you've ever been in a train at a station, stationary, and the train next to you pulls out and it feels like you're moving. That's because of the visual stimulus of the motion of the train makes you feel like you're moving, even though your train isn't moving and your head is stationary. So that's the importance of vision as a balance input. The other important input for your balance that your brain uses as a source of information is proprioception. That's feedback from your joints and muscles, particularly your ankle joints when you're standing. So that is what is giving you information about whether you're leaning to the right or to the left, whether your weight's on your toes, on your heels. Your inner ear isn't sensitive enough to sense the difference between that and that, really. Minimally sensitive. What's giving you that information is that all the weight is on your toes, and that information is being fed up to my brain, and my brain is combining that with my vision and the inner ear balance input. So all of those inputs are all working together all the time to help you move around in the environment. And that's what makes...
Should I ask them if they can turn it down? Is it bothering anybody?
It is a bit off-putting, but
Yeah.
I don't know if they've got a slightly nice thing there.
That's what makes balance such an interesting topic to investigate, because it's so complex. So when somebody comes to me and they're dizzy, I have to try and tease out, is their dizziness coming from the inputs? Is it a problem with the inner ear? Is it a problem with their vision? Is it a problem with their muscle feedback? Is it maybe a combination of 2 or 3 of those? Is it a problem with the coordination of those inputs in the brain? Or is it a problem with the output? So for example, walking, when you walk is almost a fall every step you take. So you walk forward, and if I didn't move this leg forward, I'd fall over, because my weight's being pushed outside my base of support, and I have to take a step. So every time you take a step, you're nearly falling, every time, and your brain has to coordinate the step to save you. And that's output, that's not input. And sometimes people have a problem producing the correct output that means that they're at increased risk of falls. And there's nothing wrong with their inputs. The problem is that the information's all getting in and it's all being coordinated properly, but the information is not getting from the brain to their muscles to make that step or to help save themselves if their balance is upset. So part of my job is trying to work out which of those things is going on. Is it input? Is it the central coordination? Or is it the output? So that makes it interesting because it's not easy. So that's why I like my job. Because it's like doing a jigsaw puzzle. So each of the small tests that I do, and when you come and see me, it takes a long time to get tested, doesn't it? So when you come and you see me and you have balance testing, it takes an hour and a half. So there's lots of small tests to try and work out which bit of the system is not working properly. And then I have to put that all together to come up with a picture that the doctor can use to make a diagnosis and to actually work out what name to put on your dizziness. So I'm going to go through some of the common causes of dizziness I see, and you can ask me about other things, but I must stress that I can't diagnose anyone tonight. That would be unprofessional and potentially unsafe. So I'm afraid you can't come to me and describe your symptoms and expect me to be able to tell you exactly what's going on. But hopefully some of the information I'll give you tonight will allow you to start to work out for yourself what might be going on, and then you can go and have that investigated if you want to. So I'm going to start by talking about the inner ear, because that's what you're all interested in. So I'm going to talk about 3 really common inner ear causes of dizziness. So these are things that have gone wrong in the inner ear itself, and they're very common causes of dizziness. So by far the most common thing that I see is something called benign positional vertigo. Has anyone heard of that? So benign positional vertigo, it does what it says on the tin. It's benign, so it's not dangerous. It's not very nice when you've got it. But it doesn't progress into anything else, and it's not evidence that there's something progressive or sinister wrong. On its own, it's not dangerous. The fact that it causes dizziness is dangerous. It's a mechanical problem in the inner ear, and so it's not evidence that there's anything growing in your head or anything like that. That's why it's benign. It doesn't progress into anything else. It will either carry on as it is or it goes away on its own. Those are the 2 outcomes. Or it can be treated and go and disappear. The symptoms can be treated and managed in that way. It's positional because it's brought on when you change your head position, particularly with respect to gravity. So people with BBPV describe dizziness when they go from sitting to lying, turning over when they're lying down, going from lying to sitting, or doing this. So often when they tie their shoelaces or put their shoes on, or when they bend to pick something up from the floor, and sometimes when they're washing their hair in the shower like this. So any time people move their head in this plane, that's when they're at risk of being dizzy. And the dizziness that they experience is a brief but really intense feeling of spinning or tumbling. And by brief, I mean 20 to 30 seconds. But it's really strong. So it will only be provoked by those changes in head position. So for example, when people go to bed at night, they lie down in bed, there's a couple of seconds, and then the world starts spinning, and then after 20 seconds, providing they stay still, it stops. But they'll get it again when they sit up. And it's caused by some of these small particles from the utricle and the saccule, these little stones, particles that I was talking about earlier, becoming dislodged from the jelly, where they should be, and then they can float around in the fluid that fills the inner ear, and they can fall into one of the canals. And they make the canals abnormally sensitive to gravity. And that's why you get dizzy when you go from a high position to a lying down position, and vice versa. What happens is that the particles fall into the tube, and then when you make the head position, they roll and they pull the fluid through with them, and that triggers this brief, intense feeling of dizziness. If you stay in that position, they all come to rest at the low point in the canal, and the the symptoms go away. That's why it only lasts 20 seconds. And then you get the reverse when you sit up because they all roll back in the opposite direction. About half the people I see have benign positional vertigo. So it's incredibly common. Fortunately, it's very easy to treat it. Because it's a mechanical problem with these particles being stuck in the wrong place, the treatment involves rolling the particles out of the tube back to the part of the ear where they came from. And you hope that they all stick back and it doesn't recur, but it can recur. So the treatment is a head manoeuvre. So we ask people to move their head into particular positions in a specific sequence to put these particles back where they belong. It's a bit like doing one of those mazes that you get in a Christmas cracker, where you're trying to manoeuvre the ball bearing around. It's exactly the same thing. I always think of it as like moving peas around the edge of a dinner plate. So you're trying to sort of roll the plate so that the peas roll around. The problem is, when I'm doing it, I can't see the plate and I can't see the peas. I can just see the outside. Yeah, so it's a bit like doing one of these ball bearing things with my eyes shut. Fortunately, I can use the eye movement to work out what's happening in the inner ear because they're linked by a reflex. So when people get this brief, intense feeling of spinning or tumbling, they will get an accompanying eye movement. And from the direction of the eye movement, I know where the particles are. And then I can work out which manoeuvre to do to hopefully have the highest chance of success.
So you're saying they look, so if you have it in one plane, you would sort of be looking over there, or do they flick backwards and forwards?
You get a nystagmus, so you get a repeated eye movement.
Right.
The eyes twist.
Depending on that.
Depending on where the particles are, they might flick horizontally like this, and they might twist like this. So from the direction, I can work out which canal they're stuck in, and then do the right treatment, hopefully. So that's benign positional vertigo, very, very common. Sometimes I don't see people because they don't have it persistently. They might have it for a few nights and then it goes away and it never comes back again, and then I never get to see those people. So it's probably even more common in the general population than it is in my clinic. Because I'm only seeing the people where it's been really persistent, that they've had it for long enough that they've had time to go to their GP and their GP's had time to make a referral, and then they've had time to see Mr. Aldrin or another ENT specialist, and then they've had time to come see me. So they've had it quite persistently by the time they get to me. But there's a whole bunch of people out there who've maybe only had it for a few days and it's gone away and they've never bothered to get referred. So it's really, really common. Becomes more common as people age, I'm afraid, like everything. Starts to deteriorate as you get older, and the prevalence of BBPV increases with age. So you're more likely to get it as you get older. But I do see very young people with it. It's sometimes triggered by a blow to the head. So sometimes I see people after car crashes who've had an impact to the head and that's knocked some of these particles off. Or they've had a fall for some other reason and they've banged their head and that's knocked some of the particles off. And for some people it's triggered by an inner ear infection, which is what I'm going to talk about next. But for about half the people I see, there's no trigger. They just wake up one morning, they get out of bed and they spin for 20 seconds. And then they get it every time they move their head into those particular positions. So there's not always a definite trigger, it can come on out of the blue. I'm going to move on and talk about inner ear infections. And that's called Vestibular Neuritis. Have you heard of that? No? Sometimes it's called Labyrinthitis.
Yeah.
You've probably all heard of that. And labyrinthitis is a little bit of a misnomer because labyrinthitis means inflammation of the whole labyrinth. This is the labyrinth, so that includes the hearing bit. You can get genuine labyrinthitis, but it will cause hearing loss and acute balance disturbance as well. Vestibular neuritis just makes you dizzy. So it's vestibular because it's just the balance part of the inner ear, which is the vestibular system, and it's neuritis, which means inflammation on the nerve. So vestibular neuritis is inflammation on the nerve of balance. And what we think happens with vestibular neuritis is that there's inflammation on the nerve of balance that travels from the ear to the brain. And because that inflammation is there, there's swelling on the nerve, and the nerve then can get compressed in the narrow bony tube that it has to travel through. It gets squashed. And when it gets squashed, the signals can't travel effectively from the ear to the brain anymore. So there's an interruption in the information coming from the affected ear. That reduces the information coming from that side. The information on the other side is still okay. Because one side is working and the other side isn't, that makes you feel like you're turning. You get this acute onset, usually starts really suddenly out of the blue. Sometimes people feel a little bit unwell beforehand, but very often it's completely out of nowhere. You get this really awful spinning sensation, and it goes on for hours, days sometimes. So typically vestibular neuritis will cause acute spinning, continuous spinning, for 2 to 7 days. It's incredibly unpleasant. It's absolutely impossible to do anything while this is going on except lie down and throw up. It's really, really awful. It's incapacitating, and you just have to wait for it to go away. And fortunately, what happens is that your immune system gets on top of the virus, which triggers this inflammation. So your immune system fights it off, and then the swelling goes down, and what you hope is that the nerve conduction then returns to normal. For some people who've had vestibular neuritis, have had this acute spell of days where they're spinning, the inflammation has been there for sufficiently long time that the squashing has been really bad, and it permanently affects how the signals are conducted along the nerve, and then they end up with a permanent loss of function on that side that I can measure on my testing. And so that's one of the things that I look for, is whether the two ears are working the same to see if there's a permanent loss of function on one side. So that's the type of problem that you'll get with vestibular neuritis. Anyone can get vestibular neuritis. It's usually a one-off, but some people can get a sort of cluster of spells of vestibular neuritis. And I think of it a little bit like shingles. It's the same family of viruses as the chickenpox virus that most of the time causes this problem, we think. And it's a little bit like when you've had chickenpox. That virus lies dormant in your system for the rest of your life. It lies in the nerve bundles of your body. Normally your immune system is on top of it, but sometimes if your immune system's a bit low for whatever reason, the virus can break out along a particular sensory nerve and you develop symptoms. If it breaks out along a nerve that feeds your skin, so here or on your face, then you'll get the typical blisters that go with shingles. If it breaks out along your nerve of balance, then you might get vestibular neuritis. Dizzy. So it's a similar type. You can look at it under the same umbrella as that. Usually, after the acute spells have settled down, people are a bit unsteady and wobbly for a little while afterwards, and then, providing they move around normally, things start to improve and their balance does get back to normal, even if they've got a permanent loss of function. But after you've had an acute episode like that, it is normal to be dizzy and disorientated when you move about for a period of some weeks or months afterwards. And that is where I see people a lot in clinic. They've had an acute spell, and unfortunately some of the time they've been told by their friends or another healthcare professional that they'll be dizzy for a week or two and then they'll be fine. It isn't like that. So of course when they're not fine after 4 weeks and they're still disorientated when they move about, then they start to say, well, there must be something else wrong with me. That's not the case. It can still be down to the vestibular neuritis and they're just in the normal phase of recovery. It takes a lot longer than a few days to get over it. And what the unfortunate effect of thinking, oh, this is all going to be better in 2 weeks, and then finding out that it isn't, is that when you're not better, you suddenly start to worry, what else is going on? What is wrong with me? They must be wrong about what they said at the beginning. This must be something else. Then you start to become very anxious, and one of the primary physical symptoms of anxiety is also dizziness and disorientation. And so then, when you get very anxious, you start to become more dizzy, and that makes you think, oh, there really is something extra wrong with me. If you get dizzy when you start to move around, and you're worried that it might be the start of another big spell like this really awful spell you had at the beginning, then of course you don't want that to happen, so you move around a bit less, or you move around a bit more slowly, so you don't trigger the symptoms. That feels like common sense, and in the short term that will make you feel a bit better. But in the medium to long term, it means your brain never gets exposed to the normal signals of head movement, and it will fall out of practice at interpreting them. And then you will develop longer term problems with your balance, because your brain has developed this bad habit of moving around very cautiously and helping you to move around very cautiously. And it means that your brain never compensates, it never adapts or adjusts for any change that occurred during the initial acute spell. And I see that so often. So if people who've had an acute spell, they've been completely normally disorientated afterwards, perfectly natural part of recovery, but they've been so frightened by that because the initial spell was so terrifying that they've started to move around very slowly and cautiously, and that means that they will never properly recover without help then. And that's why we're there. We try and help them to get over it. So that is one of the issues that I come up against a lot with vestibular neuritis.
At that stage where it's sort of later on, is that then too late to treat it with antibiotics like you would at the initial stage?
You can't treat it with antibiotics anyway because it's nearly always viral.
Okay.
GPs always do give you antibiotics, but it's nearly always viral, so antibiotics won't make any difference at all. Yes, it's much too late then.
So when I'm sorry, when you have an involvement with your hearing as well, how often do you see that where you actually get the hearing impaired as well?
We'll talk a little bit about that with Meniere, but with neuritis / labyrinthitis, very rarely.
Right. Okay.
It's nearly always balance.
Okay.
That I see. It's not common to see the two things together. There are particular types of virus that can affect both, but it's much more common for it to be just balance. And sometimes if there's an effect on the hearing, sometimes steroids are given, and that in the very early stages, and that can be helpful.
I was just wondering about the inflammatory aspect. You sort of saying that it depresses the nerve. So if you could actually intervene early on and stop that compression, you might not get possibly the permanent damage.
Potentially.
So if someone was prescribed an anti-inflammatory, I mean, might that work? If it was spotted initially?
Sometimes people are given antivirals, like acyclovir, and that can be helpful. But you have to give those within a couple of days of the symptoms beginning, and that's not that common. And your doctor has to recognise what it is and give the right treatment.
It must
quite
be very
difficult.
hard for GPs.
It's very difficult.
Somebody goes along and says, they're dizzy.
It's very, very difficult. Usually somebody with vestibular neuritis won't be going along anywhere.
No.
They'll be at home. But it's really, really difficult. And there's mixed evidence about antivirals, but they do have to be given incredibly quickly. It is going to go away on its own anyway, so it can just be a case of waiting to see. So let's talk about Meniere's, because that's the last inner ear cause that I want to talk about. And that you're a lot more, those of you with Meniere's will be a lot more experts about Meniere's than me, because you know how it is. But the typical symptoms that I'd be looking for with Meniere's would be episodic spells of dizziness, apparently unprovoked, so they come out of the blue. They're associated with hearing loss at the same time as the dizziness, or the hearing loss might precede the dizziness by a number of hours, and an increase in tinnitus in the same ear. So you'll get, typically it's a roaring tinnitus, an increase in the volume of the tinnitus, the hearing drops, and then a few hours later you get an acute spinning episode. And with Meniere's, the spinning typically lasts 3 to 5 hours, and then starts to reduce again. Can vary from person to person, but that's a typical spell. And those can occur utterly randomly. So people can go for years without spells and then get 6 in 2 weeks. And other people can have them much more regularly than that. So it appears to be completely random. The physiology, the pathology of Meniere's is still a little bit of a mystery. So we don't 100% understand what is causing those spells. It's thought to be something to do with the balance of the fluids in the inner ear. There may well be an autoimmune component, so a bit like with rheumatoid arthritis, where the body is kind of fighting its own defences. There might be something like that going on in the inner ear, where the inner ear is sort of triggering this off somehow. The immune response in the inner ear is triggering off these spells. We don't fully understand it, which does make it very difficult to treat it. And you will know that there are many different types of approaches to managing Meniere's. And I'll come on to treatment of anything later on. But we usually split treatment into kind of non-invasive lifestyle type management things. So looking at diet, sleep, exercise, that sort of thing, and environmental triggers for dizziness. And then you might look at medical management, which would be some sort of medication, and then onto surgical management, which would be actually physically intervening in the inner ear itself. So those are the sort of tiers of any treatment for anything. So those are the 3 main inner ear causes of dizziness that I see. There are lots of others, but those are the big 3 that I see in clinic. Just to cover 2 other really common ones that I see that are not directly caused by changes in the inner ear. And the first one of those is migraine. So there is a variant of migraine that triggers dizziness. And it's thought to be very common. There's a big overlap between migraine and Meniere's. So many people who have migraine also have Meniere's and vice versa. And the common misconception, everybody understands migraine as a really acute headache, dislike of bright lights. Sometimes people get flashing lights before the headache or a blind spot, and they have to go lie down in a darkened room for a number of hours, and then they feel better after a few hours. They might feel washed out for a few days, but they have this really pulsatile headache, thumping headache that's made worse by normal regular activities. So they have to lie down and do nothing for a few hours. It's typically one-sided, so the headache will be very strong on one side, and the headache typically lasts 4 to 72 hours with a migraine headache. To have dizziness that's caused by migraine, you don't have to have a headache with it, which makes it much harder to work out whether that's what's going on, because if there was this dirty great big headache after you got dizzy, it'd be really easy to work out whether people had migraine. But the variant of migraine that I most commonly see, typically people don't have the headache phase after the dizziness. They just have the dizzy bit. Quite often there's been a history of migraine headaches, but they might not be having headaches when I see them. They're just left with the dizziness. Migrainous brains are different to non-migrainous brains, so they're wired up differently, and they're more sensitive to particular neurotransmitters than without migraine. And it's this sensitivity to different neurotransmitters that triggers the headache, but also triggers the sensory aura that people get. We all know about the flashing light one, but dizziness is another one. Some people get a funny taste in their mouth, some people smell funny things before they get their headache, or associated with a previous history of headache. So the dizziness, we think, is part of the sensory aura that's part of the migraine complex. And you don't have to have the two at the same time. That can make it very difficult when you're trying to discuss with somebody whether you think it's migraine or not, because they'll be like, well, I don't have headaches, so it can't be that. That isn't the case. It can still be migraine. You don't have to have a headache. So that's a really common cause. That's obviously nothing going on in the inner ear. That is to do with your brain and how it's interpreting balance information. So that's more to do with this central processing. And the other really common thing that I see is something called 3PD, or triple PD sometimes. In America they like to call it triple PD. And what that stands for, so it's called triple PD because it's PPPD, and that stands for persistent, perceptual, postural dizziness, or sometimes persistent, postural, perceptual dizziness, but those three. And what that means is that you're persistently dizzy. You have to have had it for more than 6 months on the diagnostic criteria, so you have to have had dizziness over a number of months. It's perceptual because it's about your perception of motion or your perception of head position. And so it's to do with, again, the processing in the brain of that information. And it's positional or postural because it's quite often associated with changes in head position or movement through the environment. A very common symptom with this, and also with migraine, is for people to be disorientated in particular visual environments. So where they feel quite okay if the visual environment is very still, but they become much more disorientated when they're in an environment where things are moving past them, or where they're moving through a very complex visual environment like a supermarket. And a feature of triple PD is that it can feed a cycle of unhelpful behavioural response. So if you're in a particular environment, you start to become very disorientated. That's unpleasant. And because it's unpleasant, you come to fear that environment and you withdraw, and you don't want to do that same activity and go in that same environment again. And that leads people into an increasingly restricted amount of activity. They gradually start to cut off things that they think trigger or environments that they trigger their symptoms, and they very quickly become less and less active because they've cut out an awful lot of environments that they feel able to go into. And that is a problem in helping people to get better, because you have to challenge the system and help them be in those environments without it triggering this level of anxiety that triggers this unhelpful feeling that you need to get out. You need to expose your brain to those environments so that it can relearn how to integrate all of these three inputs that we spoke about properly, so that you're no longer disorientated in that environment. Triple PD is very commonly triggered by one of the other things. So you can have an episode of BBPV, you can have a migraine episode, you can have vestibular neuritis, and then develop triple PD afterwards. So it's very commonly associated with a first vestibular episode that has resolved, but then the recovery process for that has gone wrong, and the adjustment process in the brain has gone wrong, and it means that the symptoms are lasting longer than they should. But fortunately, it responds very well to treatment. And so that's the last thing I want to talk about and leave you with before I take some questions. And that is, what do we do about all of this? Well, with benign positional vertigo, it's very easy. It's a mechanical problem. mechanical treatment. So we apply the appropriate manoeuvre, and hopefully it clears the dizziness in the vast majority of cases, not 100% of cases. Anyone who comes in front of you and says, I can treat 100% of BBPV in this way, they're lying. It is the manoeuvres are not 100% successful, even in the best hands. And that's because when we're doing it, we can't see the plates, we can't see the P's, it's all a bit of guesswork. And so you can't ever be 100% successful. There will be some people where you roll the particles out, they roll straight back in again, you roll them out, they roll straight back in again, and you never quite clear it. So it doesn't work for 100% of people. With vestibular neuritis, you wait for the acute symptoms to settle, and then you help people to move around normally. And to do that, they must receive early reassurance that when they move around initially, it is normal to be disorientated. That disorientation is evidence that the brain is trying to reset, trying to adjust. It's a good thing. It's something to be embraced, not avoided. And then, though, if you receive that information early enough, you'll get better a lot quicker. So you can see pets who have vestibular neuritis. They have the acute episode, they have the nystagmus, they have everything just like humans do, they're sick. They recover really quickly because they don't have the fear response that we have. They just run about afterwards. They recover really fast, and it's the same with children. They don't have the fear response that we've learned as adults. And so they just go back to normal, moving around, and they're like, oh, a bit wobbly. Ha ha ha. They think it's funny. Whereas we as adults, we're much more cautious, much more careful. And it's adults that get into this vicious cycle of then moving around a bit less, and then the system can never adjust. With Meniere's, it's very often the case of moving on to medical or surgical management, which I won't talk about this evening. So, did Mr. Aldrin talk about that?
No, we spoke about tinnitus.
Oh, it's about tinnitus. Okay. So you want Mr. Aldrin back to talk about that because that's what he does. So he has a lot of experience in the medical and surgical management of Meniere's. With migraine, sometimes it's lifestyle management. So migraine's very amenable to changes in lifestyle. With migraine in particular, it's very important to maintain regular habit in what you do. So regular sleep pattern, go to sleep at the same time roughly every night, wake up at the same time in the morning, eat at regular times of the day, never skip a meal, take regular exercise. That dissipates the stress hormones that build up in the body and can trigger an episode of migraine. So these lifestyle changes are very often successful in bringing about control of the symptoms for people with migraine. If not, then we move on to medical management for that as well, so some sort of medication. And with triple PD, it's a case of physical therapy, so encouraging people to move around normally and in a helpful way, but also challenging the situations that they find very disorientating and helping people to manage the symptoms in those environments with a helpful behavioural response rather than an unhelpful one. And sometimes we do that with the help of a cognitive behavioural therapist that I work very closely with, and that's around changing people's responses to dizziness so that the dizziness doesn't last such a long time and they'll recover a lot better, and they are then in control of the dizziness rather than the dizziness being in control of the activity that they're able to undertake. So that's all I plan to say about the most common causes of dizziness that I see in clinic, and the kind of global types of treatment that we apply. My final parting thought would be to say that regardless of the cause of dizziness, it's incredibly important to keep your inner ear balance system stimulated. Because if you don't use it, you will lose it. It will not function effectively. So it's very important to move around, to engage in activity, particularly activities that involve eye and head coordination. Those are the best ones to stimulate the inner ear. Those are the ones that are missing from a lot of general fitness things that people do. For example, yoga and Pilates, they're very head static. They're great for your proprioceptive feedback and your core strength. They don't do anything for the inner ear. So what's really important is that you're doing something that involves head and eye movement.
Sorry.
So table tennis.
Table tennis is great. Any tennis, badminton, table tennis, because you're moving your head to focus on the ball, absolutely brilliant.
I've been to a few exercise classes where you sort of, you know, up and down, and I can't do it. But is that my perception that I can't do it? It actually makes me feel dizzy. But should I carry on? Would it, you know, would I tolerate it, my dizziness better if I made myself do it?
You might. So repeated exposure,
Yeah.
your brain, just like, that's habituation.
Yeah.
So just like when you walk into a room and there's a strong odour, you smell it.
Yeah.
But if you stay in the room for about 15-20 minutes, you can no longer smell it. And that's because your brain is habituated to the smell. The scent is still there in the air, the scent molecules are still there, they're still going up your nose and they're still binding with the receptors in your nose, but your brain is switched off responding to them. And the same thing happens with movement. So if you repeatedly expose your brain to a particular movement, your brain will switch off responding to it.
Really?
That's what gymnasts and ballet dancers and trampolinists, that's what they do in training.
Yeah.
Is they spin and spin and spin and spin and spin until they don't feel it. Or they can control that perception of motion. There are some amazing videos on the internet of people, divers in particular, spinning and spinning and spinning and spinning on a rope. You know, they've got a sling, a harness around them, and they're being spun by their coach, so that they, when they touch down, they're not dizzy.
Makes me feel dizzy.
Obviously, I'm not suggesting that you do that, but
That's not happening.
that shows you the extent to which the system can be trained.
Yeah, because I've never even, it had never occurred to me that you could habituate to your dizziness. I just thought it was there and you just avoid it.
No, habituation is one of
It's
the
counterintuitive
mechanisms.
because
It
you
is.
don't want to feel dizzy.
No, absolutely.
So you don't move your head.
Exactly right. And 90% of the physiotherapist job that I work with is persuading people that actually, short term, yes, you will be disorientated when you do this, but the more you do it, the less disorientated you will be. So if you're doing your exercise, I'm not saying that you just keep doing it and push through it, because you'll just make yourself really, really dizzy. But the critical thing is to do it when you start to feel disorientated. Stop, have a rest, do it again, then do it again. But you know, cut yourself some slack, have a rest. But what I see a lot is people who do a particular movement, they get very disorientated and they never do it again. That's not helpful. So if you can get some repeated controlled exposure, your brain will adapt. It will habituate to it.
You sent me for the vestibular rehabilitation, and the exercises that I was given as part of that are just repeated eye and head movements, quite some of them quite rapidly. But I can see now from what you're saying, what I was told at the time, that's what you're doing. You're making, it's doing it until you're dizzy, effectively, just to get everything working again.
Yes, that's right. Because the disorientation that you experience, that error signal, is what your brain needs to tell it that things aren't quite finely tuned and that it needs to make an adjustment. If you move around so carefully that you never trigger that disorientation, your brain won't ever know that it needs to do anything. And so it won't try and make the adjustment. And that's the idea behind the exercises, is to give people some controlled exposure to these symptoms so that the brain gets the right reset signal. And then it will do that, but it does need repeated exposure. That's why you have to do it again and again and again.
How long do you have to do them for?
It varies from person to person, and according to the cause. So what would happen if you went to see a physiotherapist, if they would tailor the programme to you. Typical recovery, unaided recovery, we usually say 12 to 16 weeks. So that's if you just move around normally and you don't have any specific intervention. For some people it takes longer, and for some people it's much, much quicker than that. So it varies. But the physiotherapist or the audiologist or whoever's doing your exercises with you will tailor the specific type of exercise that you do and the speed that you're doing it at, so that it's manageable but it's pushing the right buttons. And for some people we have to take it very slowly because they can't cope with anything more than that, and they have to take smaller steps, but they'll get there in the end. And for other people, they might make a big leap 1 week and then have to take smaller steps. So we have to judge it on the individual. I can't give you a one-off answer to that, sorry. So I think more people should be doing exercise like tennis and table tennis.
Which I do. I came here because it was a vestibular thing and it was balance stroke dizziness. Well, thankfully, listening to the problems with dizziness, I'm glad I haven't got that. I've got a vestibular schwannoma, for which I was given gamma knife therapy about last August, not this August, the previous August. Hearing loss, slight problems in the face, waiting for the results of the last MRI I had for this. But what happened is that walking into town with my wife, and every now and then I'd sort of walk into her, or especially going down where there's trees either side down the path, I'd be walking off into the tree, went and saw the doctor. She sent me for a brain scan when I thought she was going to say my knees are giving up. And came back with a vestibular schwannoma, just over 2 centimetres large. Did a lot of stuff on the internet and found out that if it reached 2.5 centimetres, they can't do anything with gamma ray, and it'd be open surgery. Pushed hard with the local NHS and was sent to Sheffield to have the gamma ray. Hearing loss after the gamma ray has gone down somewhat, and it's worse. Tinnitus is about the same, but the balance is getting a little bit better recently. But if you ever get anything where you tend to wander off your normal line, don't hesitate and go and see the doctor. It's a little bit like you've had a couple of wines too many, but you haven't touched it.
Yeah.
And,
so I haven't spoken about acute neuroma or schwannoma today because it's rare. So I've only covered the really common things.
Yes.
So you're quite rare and exotic.
250,000 or something.
Yeah, it's relatively rare in terms of causes of dizziness. And you're absolutely right, that's a very slow change in your balance. So you do end up with a permanent loss of function on one side, but it happens very gradually. And so this adaptation process that I've been talking about, that happens as you go along. But eventually, so you never get this acute spinning I've been talking about. But eventually you end up with a permanent loss. And that's what can trick your brain into thinking that you're being pushed to one side. Because the good side is kind of pushing you over to the weaker side. It's sending stronger signals, and it tricks your brain into thinking that you're moving in one direction. That's why you do
2 or 3 steps sideways and think, let's get back to the where I was going.
Yeah.
Good
But if
results
if you've got unilateral symptoms like that, so you've got tinnitus on one side and hearing loss on one side, and if you're drifting to the same side, you should definitely get that checked out.
They do a crossover hearing aid as well now, so that my left side, which is the side that's gone, when I'm sat in the car with my wife speaking to me, I get the sound in this ear.
Yeah.
And the brain is now making up for that, so that it feels like it's not still coming from this ear, feels like it's that ear, even though that's not really hearing it.
And the same will be happening with your balance. So although you will have lost some function on the affected side, your brain, because it's no longer changing, that's what we hope, that's the idea, is that now it's a stable position and your brain can properly adapt to that. What was happening before is it was dropping all the time very slowly, and your brain could never quite catch up, and that's why you were so
Well, I did discover as well, the faster you move, the smoother it is, because you overcome the tendency to wander. But I cannot for the life of me do the American police are you drunk walk of heel to toe, heel to toe, heel to toe. I have just felt
It's very difficult. It's very difficult to do that, but for anybody with a balance problem, this is exceptionally difficult. Even somebody with completely normal balance, that's hard. So yeah, that would be ultimate perfect recovery if somebody was able to do this. And you're absolutely right. The reason it's easier if you walk quickly is you're in contact with the ground a lot more, and so you're getting good proprioceptive feedback there, much better than if you're walking very slowly, where you're actually standing on one leg for a lot longer each step, and so it's much harder. Whereas if you're walking quickly, you're actually much more stable.
If you've got balance problems then, should you avoid doing balance exercises?
No.
Or you should challenge yourself
Yeah.
to do them?
In a safe environment,
Yeah.
preferably with supervision, so
Okay.
somebody, not somebody there watching you while you do it, but somebody who is helping you to pick out the best exercises that are really going to work for you.
I was
and
thinking
be
if you
most
went
effective.
to a Pilates or a yoga class.
You should, any kind of activity is good,
Okay.
within your limits. So
Yeah.
making sure that you're safe.
Yeah.
So if, for example, in yoga, if they're doing tree pose
Yeah.
or whatever, be next to the
Okay.
wall.
Okay.
So know your limitations at that stage. But as you do it, the more you do it, so I'm completely hopeless at tree pose. I do yoga, but I'm rubbish. So I've got terrible balance. I should heal myself. If you're standing in tree pose and you're touching the wall, as you get better, you can let go for longer periods.
Yeah.
But stay next to the wall just in case you have to touch it. That's, so make sure that you're safe from it. But any kind of activity is good, and it can be good to start with something that's a bit slower, like Qigong or yoga or Pilates. That doesn't involve quite so much head movement,
Yeah.
but there is a lot of lying down, sitting up, which can be a problem for some people. The best kind of exercise you can do, or if you're able to do table tennis and everything, that's fantastic. But if you're not quite up to table tennis, the best kind of activity is walking outdoors. And particularly if you're able to look around a little bit as you walk. So what a lot of people who have balance problems do is they fix on something ahead of them and they walk like this, because they don't want to move their head. And actually what you need is the head movement. So if you've got somebody next to you, my slide showed two people walking along and chatting to each other, which I can't show you. So it's nice if you're walking with somebody, if you can chat to them and then you're looking around, you're moving your head, you're looking at different things and walking at the same time. So I'm not suggesting you walk along like this, that'd be crazy, but just looking at different things around you, because that combines the movement perception that you need from your muscles and joints, visual input and head movement. That's hitting all three bases all at once. So it's a win-win kind of exercise, walking outdoors. The reason I say outdoors is because that wider visual environment is a much richer, more beneficial, more stimulating environment than being indoors and walking only where everything is close to you.
I've noticed through talking, not just here but with other people, a lot of the people who do suffer from severe tinnitus have balance problems. Has there been a proven connection between the damage that's been done to the ear to cause the tinnitus and balance?
Only with specific things like Meniere's or
Nothing
Labyrinthitis
else.
or schwannoma. There are specific conditions where they're linked. There is an effect of age. So, am I right that tinnitus gets more common as you get older? So, I'm not an expert on tinnitus, I'm sure.
Can you just tell us briefly what tinnitus is? Just summarise it very briefly.
A noise in the ear or head that isn't present in the environment.
Sorry, what's it caused by?
Many things. We could have a whole lecture on that. But it's a noise that's present in your ear or head that isn't external. It's not caused by something external to you. And there are specific things that will cause both, and age is one of them. So as you get older, you're more likely to have hearing loss that's associated with tinnitus, so nerve damage to the cochlea, the hearing bit of the inner ear, and also the balance bit of the ear wears out as well as you get older. and so you get age-related loss of function. But you can do a lot to put that off or make it happen a bit more slowly if you remain active. And that's why fitness professionals should know a lot more about the inner ear. Especially as we're all getting older, the population is getting older, so the population of people using gyms is getting older. These people who are training people in gyms need to know this stuff. They need to understand what the inner ear does, and at the moment they don't get any training.
Can you do that? Can you train? Can you train a trainer?
I can train the trainer. That is what I would like to do, and that is what I am doing. So I do go out and deliver training to fitness professionals, physiotherapists who are working in high-risk populations to help them embed vestibular exercise in the other stuff that they're doing. So it's very simple to do. So for example, if you're stretching after you've been exercising, your head's very still, the rest of you's very still, just chuck in some head and eye coordination. So if you're stretching your hamstrings like this, you can look at the toe and move your head at the same time. That's a balance exercise. And you're still getting the stretch and all the other benefits. So you don't have to give up something to fit the vestibular exercise in. You can overlay it on whatever else you're doing.
Did you fix your eyes on your toe then, or were you actually moving?
I was looking at the toe.
So you're moving your head but keeping your eyes focused.
And that's very important. So
yeah.
Just looking around, moving your head around at random, that's not so good.
No.
So what you need is to fixate on something so that your brain is having to coordinate the eye and head movement together to keep fixated on the target. That's what your inner ear does. It keeps a stable image on your retina during head motion. And so you're working that reflex by doing these types of exercise.
And as you described earlier, use the did you say when the eyes flick?
Nystagmus.
What's that one called?
Nystagmus.
Nystagmus. Right. I mean that's when your brain you try to keep stationary when you're having a spinning attack, but your eyes you just can't.
Yeah. So that nystagmus is being generated by the change that's occurring in your ear. So that's pushing the eyes in one direction. Then your brain makes a central correction, and then you get this flicking eye movement during the acute spell. It's exactly the same eye movement you would get if you went on a roundabout and then got off and you feel like you're turning. If you're able to look at somebody's eyes when they do that, they will have a nystagmus. It's the same eye movement if you're sitting opposite somebody on a train and they're looking at the scenery, flicking by, that's nystagmus. It's the same, exactly the same thing, just caused by different situations, but it's the same type of eye movement.
Do you have any other information on exercises? As in, do you have like a website that we can go to for ideas?
Sort of exercise.
There are lots of websites about vestibular exercise.
Okay.
So vestibular rehab, if you Google vestibular rehab, a ton of stuff will come up. And you will see that they will all incorporate eye and head coordination. That's the critical part of it. And that may or may not be combined with overall balance exercises as well. So you can challenge the rest of the system at the same time. So a typical progression would be to start people doing eye and head coordinations exercises sitting, and then get them to do the same standing on one leg. And we're doing other more complex challenges. And if you're working with elite athletes, then you get them to do really difficult things like standing on a wobble board and throwing a ball and catching a ball. So you can, the sky is the limit for doing that type of exercise, but the fundamental bit is to include this eye and head coordination. But yeah, if you Google vestibular rehab, there's so much stuff. If you look on YouTube, there's loads.
How frequently do you want to do these exercises?
That's a really good question. So the frequency of exercise is really important. This adaptation and habituation process that you're trying to promote in the brain requires repeated frequent exposure. So each individual exercise should be practiced for 1 minute to 2 minutes at a time, because that's how long it takes for the habituation process to occur in the brain. And you need to be doing it 2 or 3 times a day. To give your brain this regular practice. Consistency is really important. Not forever and ever, but until it no longer provokes the symptoms. And then you can step up the difficulty. So I would get somebody to practice doing this sitting down until they felt stable, doing that for 1 to 2 minutes. When they can do that for 1 to 2 minutes without provoking disorientation, then we'd move on to doing it standing. Then they'll be a bit wobbly while they do it. But the more they practice, the less wobbly they'll get. And then we can move on to one leg. You up the difficulty like that. You can also up the difficulty with speed. So very typically, if I'm seeing somebody when they've just had their episode of vestibular neuritis, so they were dizzy 2 days ago, really acutely dizzy 2 days ago, and they've just made it into the clinic, they have to start doing it very slowly. Because any faster than that, and they become really disorientated. You only want to trigger a controlled amount of disorientation, not this. So just a small amount of disorientation. So you might need to start very, very slowly, and then you can gradually increase the speed over time. Speed you can get through quite quickly. That does adapt fast. And then you build in the extra difficulty with the other balance challenges as well.
If you've had an Epley manoeuvre, how soon should you start doing these exercises?
If you've only got benign positional vertigo and the Epley manoeuvre works, you don't need to do these exercises.
Really?
Because your BBPV should no longer be there.
Okay.
Because the particles are back where they belong,
Yeah.
you no longer have benign positional vertigo. The primary cause of your dizziness is no longer present. So if you're still dizzy afterwards, some people with benign positional vertigo feel a little bit unsteady for 2 or 3 weeks afterwards, and it settles naturally, providing you move around normally.
Okay.
If you're persistently dizzy with head movement after that, and you've been tested again, and it's no longer benign positional vertigo, so these particles are no longer moving in the wrong bit of the inner ear, then it's beneficial to be referred for physiotherapy. So I would say if you're still dizzy after having the Epley manoeuvre done, and somebody has retested you to make sure that you don't still have BBPV,
Yeah.
I would say 4 weeks was long enough. You will know after 4 weeks whether it's properly gone away or not. Yeah.
Is it common for it to be recurrent, the BPV?
Yes. So 4 out of 10 people that I see get it again at some point in the future. It is really commonly recurrent. 6 out of 10 don't. They just have a one-off spell, but for a lot of people it becomes recurrent. And we don't understand why that is.
What percentage would you expect to cure, albeit temporarily?
Never talk about cure with BPPV. It's about treating the symptoms at the time.
So what percentage would you expect to treat successfully?
On a single manoeuvre, so a single Epley manoeuvre, or other, it isn't just the Epley manoeuvre, there are other manoeuvres that you can do. So a single manoeuvre, the success rate's 75% for me, and that's in line with the literature.
Yeah.
High. That's a good success rate. And sometimes we do it a couple of times in a single treatment episode. So sometimes I'll test somebody and then complete the manoeuvre, and then I'll ask them to sit up again, and then we'll just repeat the whole manoeuvre again. Because I'm looking for it to be completely clear all the way through, and then I'll have to send them away. And then I'll see them again a week later to check that it's stayed away for a whole week. So.
Can I just ask, was it just really, I've had BPV and Meniere, is that just bad luck?
No, that's quite common for
It
the
is
two
common.
things, yeah.
Oh, right. So how come? Just because, what's the connect? I mean, obviously the connection is the inner ear, but
We don't know
You don't
what
know.
makes it, because we don't really know what's going on with Meniere either.
Yeah.
We don't know what it is about a Meniere's ear that makes benign positional vertigo more common.
Right.
Maybe the neutricle or the sacula is less good at holding on to these little particles, and so they're more likely to fall off. Something about the fluid dynamics makes that more likely to happen. We don't know, but it is more prevalent with people with Meniere's.
Referring back to the gentleman over there who's talking about problems when walking in a line, is it your recommendation that if it happens when you're walking slowly, to actually walk faster to try and counteract that?
Yes and no. So, if you're finding, some people find, and it may have been before you had the schwannoma treated, that they are unsteady when they walk very slowly, and they have to walk with a very wide base gait like this to help them feel steady. And they can't speed up, because as they speed up, they just get carried away with it, and then they're more likely to fall. So you have to be really careful. But sometimes it is easier to have that more fluid motion and walk more quickly. So you have to sort of experiment with your own walking and see what feels safe and what feels easier for you. Some people will recommend using a stick or walking poles, because that gives you extra proprioceptive feedback. So it widens your base of support, makes you much less likely to fall. You can walk more quickly with the aids, which is better and easier for the rest of your input, and you're staying safe while you do it. So sometimes using an extra form of assistance like that is helpful in increasing the speed but keeping people safe. Does that answer your question?
Sort of. Mine comes and goes.
Yeah. So for some people it will be easier to walk more quickly, and that you will feel more steady when you do that. But for other people it does make it more difficult, and it's easier to increase the speed by using a walking aid as
Trouble
well.
is, my wife walks slowly, so I end up having to wait for her to catch up.
You're 6 miles ahead of
Well, thank you very much.
Thank you very much indeed.
And apologies once again for the lack of projector.
That's all right. I hope you didn't miss the slide.